Perfect. So I think we've got everything we need then, basically. Now, sound-wise, can you guys hear me quite well?
Yeah.
Yeah.
I think we'll just get started. So hopefully this will only take about 20 minutes, but it's a good start. So morning, guys. You all know me anyway. My name's Steven Fong, for those who don't. I'm one of the gastroenterologists at the Conquest. So I'm hoping this is the start of really a interesting new set of things we're going to do for everyone to help people learn and develop. And so the idea I have in mind is that we start a kind of a virtual Microsoft Teams teaching program for endoscopy. And basically the basis of that is we're all working very hard, but I think sometimes when during COVID times, everyone's feeling a bit depressed that are they actually learning or improving themselves. So the purpose of these programs, which can happen every once a week on a Thursday or every 2 weeks, is that we can cover topics that you find relevant, that you feel you're not as knowledgeable about, that you want to improve. And that can include things like endoscopic hemostasis, anticoagulation, how to do a polypectomy from both endoscopist side and the nurse's side. It's important for you guys to know as well that, let's just add people, that on top of what we have now, actually, we also have videos that I've managed to get on behalf of the United European Gastro Society. So for example, and you can tell me if this video you can hear it. Every week, if we don't have a presenter.
Good day to everybody. Thank you very much for the nice
Can you guys hear
introduction.
Yeah.
And the purpose of my short talk is...
So basically, every week, these videos are only 10 minutes or so. You can actually, have education on things like that. So hopefully over the year, what will happen is that you guys will be much more familiar with different areas, and we can have a whole structure for the year about what presentations you want to see and things. How's that sound?
Right.
Yeah, they're great.
Okie dokie. So that's the grand plan. But for today, the basic thing that I really want to do is cover how nurses and endoscopists deal with patients in IBD and endoscopy, particularly making sure that our endoscopist knows what's the right score for IBD and how to recognize it. And that's important not just for the scopists, but for the nurses as well. Because I think you have to hold your endoscopist to account as well that they are doing the right score for the patient. Also, we want to talk a bit about what happens afterwards, because sometimes there's a lot of variation about what the endoscopist will recommend the patient have. Do they get started some treatment? And sometimes one problem we find is that we see a patient 3 months later with a new diagnosis, no treatment started. Patient doesn't really know what's going on. So the second part is actually giving a good idea what maybe you guys should do once you've got that diagnosis with a patient who's probably scared. We're going to start with scoring first. And like I said, why bother? If you do a IBD scoring at endoscopy very well, it will tell me a bit about the prognosis for the patient in terms of how bad the disease. It helps us tell the diagnosis of patient. If you do a scope and you're not very specific whether it looks more like Crohn's or colitis, or give us the information to help that diagnosis, it's very hard for us to say to a patient you have Crohn's or colitis. Now, you might think, what's the difference? They've got IBD, but if you do a survey of all the patients, I promise you, most of them will say one of the things that gives them most anxiety is the fact they don't know if they have Crohn's or colitis. So if you think about it from the patient's perspective, this is very important. How bad the disease will tell me whether I can increase treatment or should I stop treatment. Okay. So, and also patients, their symptoms, they might say, oh, Dr. Fong, I'm really bad with my symptoms. And you do the scope and it's normal. So there's a reason why we want to report it well, so that we know exactly what's going on. I'm just going to put you on mute for a second, Myra, or whoever. So it's just so we don't have too much feedback, but you can unmute when you need to, I think. Let me just, okie dokie. So now, I would just like I was saying, for UC, our endoscopy has two particular purposes. One, we want to know in the acute stage when they're active, how bad it is, to tell us whether this is a patient we can escalate treatment or they need surgery. But there's also the second part, when the patient is well, the disease is stable, sometimes we still need endoscopy. For example, we might need to do chromoendoscopy to check for dysplasia, particularly in patients that have had their colitis for more than 8 years or so. Also, if we can see that the disease is really well controlled, by doing a good endoscopy and a good report, we can decide whether it may be possible for the patient to stop their biologic treatment or other medication. So don't just think that endoscopy is for when patients are in the active disease. It's also when they're in remission. So at both times, having good endoscopy reporting and how to manage them is very important. Now, there are other things worth thinking about. It's also about how far you go with the scope, because a lot of patients, they might have a flexi sig, and sometimes you pick up the colitis then. And the truth is, for most scopists, and this is not really something I guess you have to think about at the start, is when we see them later, we'll probably want to do a colonoscopy. And you might say, why? You've already got a flexi sig, you can see colitis. Well, patients who only have left-sided disease have a slightly different prognosis compared to those with pancolitis. So that's why later we like to do a colonoscopy. So for those of you see IBD patients in your clinics, whether you're gastroenterologists or surgeons, think about doing a full-on colonoscopy if they've only had a flexi sig in the past. Don't use that as the only test, because as you can see, up to 30% of them, the disease will extend. It will go further beyond the left colon. And so these things are important. Little things we should check about is backwash ileitis, which you can sometimes see with ulcerative colitis. And what you have, because you might mistake it for Crohn's, is you got very clear ulcerative colitis, very continuous pattern at the left colon, and then a little bit of inflammation at the terminalium. So that might be Crohn's, but there's a decent chance it could be backwash ileitis too. So when in doubt, describe what you have, but just be aware that sometimes you see that with colitis too. When at all possible, particularly in IBD, especially in the index diagnosis, you should really intubate the terminal ileum properly. And if you can, take biopsies or assess it very well. So some people, there's this thing we sometimes see where it's someone with a calprotectin of 700, they have the colonoscopy, but for some reason the endoscopist decides not to intubate the terminal ileum, doesn't really tell us very much. So we see these patients in clinic, the colon looks normal, but they still have a calpro of 800, they have symptoms, and then you have to end up telling them they either need another scope or they need a capsule. So really, I would recommend that you try to get a TI intubation. Now, if your endoscopist is saying, no, I don't really like doing TI intubation, you got to ask yourself, why are you doing these scopes for patients with suspected IBD? So we're going to talk about ulcerative colitis scoring because that's the bulk of what you see. The key here is to know that over time, there have been so many scores, so it can get very confusing. But in reality, actually, the two scores you're most going to be familiar with is the Mayo score and the ulcerative colitis endoscopic index of severity. The Mayo score is much older, and it's probably one that you're most familiar with. Now, the reason these scores are most popular is probably because they're easier to use. Most people are familiar with them. They're reproducible. Validation, though, for the Mayo score is more of a question mark. So really, in reality, the preference at the moment is the UCIS. But I'm going to tell you a bit about the Mayo score just so you understand why it's falling out of favor. It looks easy. You got 0, 1, 2, 3. And basically, it's used a lot in trials before. But this K lab value is really telling you that it's very low in terms of people agreeing. So you could have endoscopist number 1 who says it's Mayo score 2, and no one's going to disagree and say it's Mayo score 1. So there's very poor agreement basically with things. So that's why it's not a very accurate score. And a good way to show that example is if you have a look at this. This is a very old picture guide for Mayo scoring. I want you to take a few seconds to look at this. And actually, I don't know, Mara, if you can unmute yourself now, but I'd like to see the nurses, if they can tell me, is there something a bit weird about these pictures? Can anyone pick up something interesting? So you see you've got Mayo score 0 here, this category, Mayo score 1, Mayo score 2, Mayo score 3. Anything unusual you notice about these pictures?
Haven't they got the same picture at the bottom of the Mayo score 1 and the top of the Mayo score 2?
Oh, Simon, gold star. You see,
Boom.
this picture and that picture is the same. So you can see actually the problem with the Mayo score is while it seems easy, the degree of differentiation between two can be very misleading because what you think is Mayo score 1, some people might consider Mayo score 2, and even the people who write the guides seem to be a bit confused about that. So I think that's a very important reason why Mayo score is out of favor. So for those of you who are using it, I recommend thinking about using something else because of that degree of discrepancy. This is maybe a bit of a clearance score for Mayo, which is, as you can see, you get loss of vascular pattern, increased erythema, then this is severe. But as I said, I'd rather perhaps move to something else, which you're probably familiar with. But for those of you who haven't heard of it, the UCIS is probably what we normally recommend for IBD scoring nowadays. It looks more complicated than it is, but the important thing actually, it's very well validated, and the agreement between different endoscopists is very high, as you can see from that R2 score. What it is composed of, number one, the vascular pattern. For example, if it's normal or if it's partially gone or obliterated. Bleeding score, whether you've got no bleeding, a bit of bleeding in the mucosa, in the lumen, or lots of blood in the lumen. And finally, the degree of ulceration, small erosions, superficial ulcers, or deep ulcers. But the most easy way to see this probably is through pictures. So this is probably a better diagram where you see you got all this normal vascular pattern. As your colitis gets worse, it all disappears. And when it's really bad, you can't see anything at all. Bleeding, a bit of mild bleeding in mucosa, more bleeding in the lumen, and then you can see lots of frank blood. And finally, ulceration, normal, small erosions, superficial ulceration here, and then deep ulcers. So you can see actually this score is a bit clearer about what you need to look for. And the three parts of it, it's not that hard. It's vascular pattern, bleeding, and ulceration. And I really recommend to everyone who scopes patients with IBD or new IBD to put this in your head, because there's nothing more infuriating than for us to see a patient in clinic and the report just says colitis left colon. It does not tell me anything about the severity. It does not tell me about whether it's Crohn's or colitis truly. So I think this is where, the endoscopist has a very strong role to help guide future management for these patients. Now, like I said, when you compare it, the validation for the score is good. And more importantly, we do calprotectins to assess disease activity. With the UCIS, the higher your calpro goes, the higher the score goes. So there's a good correlation with how accurate it is to predict this, or well, to show you how bad the disease is. So when you get a UCIS score of 6 to 8, it is quite bad disease, and the calpro is also normally quite high. So you can see it correlates quite well. It's probably more accurate. This is really a score to show you that when patient reports symptoms to you, it's very interesting that sometimes they can report lots of rectal bleeding and things, but when you do the scores, I mean, this uses Mayo, which is not perfect, but you can see that even at the no rectal bleeding, and which is RB, you have people who have a Mayo score of more than 1. So actually, scores are not, symptoms are not very good at telling whether someone's got active disease or not. So that's why we need calpros and good endoscopic scoring to tell us what's going on. As I told you, if you use a calpro, sometimes you can see even with someone with supposedly normal endoscopy, if you have a high calpro and normal endoscopy, it still shows you're going to have a relapse. So it's very important to say that what you see is really, really important, how you describe it, and to look very closely rather than just assuming it's IBD. I just need to have a very quick look. So having said that, well, guess what I'm saying to you? There's two parts to this. Now, really, the key part that me and Sophia, one of the IBD nurses, wanted to say is what you have to do basically when you have a new IBD diagnosis. So for the endoscopist, it's about using the right score. But after that, after the scope, it comes the next important bit. And we're not asking, we know endoscopists have a very busy list. So we're not asking you to make a full management plan. But often what we find is we see these patients 2 months later, they write the diagnosis of a colitis. no treatment given or no advice given about who to see. And they come back in the clinic 3 months later going, no one's told me anything. I'm bleeding now 20 times a day, diarrhea. What do I do? So that's a big delay in treatment. So if you look at that, actually, what I would suggest, I mean, you've got to get a rough idea about severity. So using the right score, but letting us know early. I think it's probably not good enough to just drop an endoscopy form, a report on the table or something, or say book a 3-month clinic. Let us know early, particularly for a new diagnosis. You can email us, okay? Something the endoscopist has to do, and I gather not everyone might be as experienced, is to consider if this patient needs some urgent treatment, particularly if someone's got very severe colitis. Speak to either gastroenterologist or to call an IBD nurse if you're not sure whether you need to give them emergency course of steroids or mesalazine and give them FP10. One thing that I think is really terrible is to leave a poor young person with active colitis for the next 3 months without any treatment. That is really, I think, not very good care. Appropriate follow-up, usually you may not know when to see them, but if you let us know, at least we can start booking them into the appropriate clinics. So I think the key here and the weak link is endoscopists or nurses need to let us know. I think preferably by email. You don't have to write the big spiel. As long as you even just copy the endoscopy report and email it to us, we will then at least very quickly know whether we have to get them in. For the nurses, these patients are going to be scared. It's the first time. They'll probably have heard that IBD is a chronic diagnosis for the rest of their lives. They might need surgery or treatment. So the key is to make sure that to keep them relaxed and calm if you can, and make sure they go home with the right contact details. Make sure they have our cards. If the IBD nurses are in the conservatory, please get in touch with them, because that just allows us to see them quickly, say hello, they have a friendly face. Things that we might sometimes think about, if they haven't had up-to-date bloods, if the last blood test was a year ago, I might want up-to-date bloods, because if I see them in clinic in 2 months' time without any bloods, that's a lot more time lost. So I think it's very important you realize that some of the aftercare, getting it right the first time, can make a big difference. So anyone want to ask any questions about that for the time being? I'll stop there just for a few minutes.
Steve, what's your preferred first-line treatment for acute colitis? So if we find one on endoscopy, what do we prescribe?
I think it's quite tricky. I think it depends on the endoscopist and how well trained they are with IBD. I mean, if it's a fairly relatively clear-cut diagnosis of a mild ulcerative colitis, then I think it's reasonable to consider mesalazine like Acecol, and they're all written on our trust formulary. But when in doubt, basically, as long as you let me or Sophia know very quickly by email, we can always send them the FB10. But yes, if you're fairly confident it's a mild colitis and it's fairly clear-cut, it is. Mesalazine is my usual call. Obviously, if you're less sure and it's very severe colitis, then we would think about steroids. But if you're unsure whether that's safe or not, then let us know. We can, get in touch quickly and start treatment, or ask the GP to start steroids. What we can't do is, if we get the endoscopy report 2 months later saying, please see this patient, that's when we've lost time, basically.
Would there be any value in a trust policy or something in every endoscopy room, just so, it's a no-brainer?
Yeah, that's not a bad idea. I think I would be careful with exactly being too prescriptive about what we give. We can give some rough idea. It's just that different cases of IBD will be different, and the experience base for the endoscopist might be quite different. Actually, you might have a new endoscopist. You might have someone who's not familiar. So, but having some kind of guidance is not a bad idea. I think that's part of the reason for doing this presentation, because we'll have this readily available so people can refer to it. But if you want, I think it'd be good to work together to try to get a little bit of a policy. I don't know what everyone feels. Myra, how do the nurses feel about that?
Any answer? Sorry, Dr. Fong. I'm sorry, I've been in and out of your training. I'm so sorry, but Robin and Margaret is here.
Okay, I think it's
my
not
only
bad
question
idea.
is, have we recorded this, Dr. Fong?
Sorry?
Have we recorded your presentation? Because I was
Yes,
trying to
yes.
record it.
Oh no,
Yeah,
the presentation's recorded. Don't worry. But I think, yeah, we were just, Mr. Shaw was just asking whether we should have like a small policy so nurses and endoscopists know maybe what
Yes,
treatment to
yes,
start.
please.
Yeah.
Yeah, we're going to do that because as you know, we have all the protocols for everything that we do inside the room. So
Yeah,
that would be really good. And we have some guidance from both JAG and
absolutely.
BSG also. Yeah.
And I think having the right score, and I know Kim's probably who's one of our new IBD nurses at Eastbourne site. She's logged on, and she will probably, I don't know if you want to say anything, but Kim, but please do so if you want. But I think letting our nurses know early when you have a new diagnosis or even a old diagnosis that's flaring, if you let us know by email, we can act on it. We can't do anything unless we know, basically.
So it has to be email. Okay, because we used to leave a report by the desk.
Yes.
Email would be the best.
I think email is safer, and so I think you should ask the endoscopist to email or at least someone, because now with COVID being quite rife, our nurses are most likely be working virtually more often than not. So relying on them coming back to the conservatory or the office to pick up a report is probably quite risky. It goes the same for patient with known colitis or Crohn's. You still should do the right scores and refer to the service. The only extra thing sometimes with patients with known IBD, they're on biologics, they sometimes have CMV infection. So you should always be thinking in a known IBD with active disease, ask the endoscopist if they haven't decided that when they do the histo report to ask for CMV testing. Because once you send off the request and you don't ask for CMV testing, it's much harder to get it done. So really think about that in someone with known IBD that has a quite bad flare, because sometimes what we notice is that if you treat the CMV, the colitis might improve as well. Okay. Blood tests, like I said, it depends. Sometimes the endoscopist is like me. If I know this patient's heading to biology, I might ask you to do extra bloods, but that's a specialist thing. So I wouldn't say that's something we have to do for everyone. Okay. Hopefully that's ulcerative colitis in a nutshell. I'm going to have a very brief run through about Crohn's scoring system, which is a bit trickier because they're a bit harder to do and there's no ideal one. Okay. But the ones you're most familiar with will be the simple endoscopic scoring system for Crohn's and root gut score. So we'll quickly run through that. The simple endoscopic score basically is a little bit unwieldy, but essentially is looking at the size of your ulcers to give you scoring, how much of ulceration is in the colon, so more than 30% scores the most points, how many segments are affected, and the presence of any strictures. What happens is you calculate that for all the 5 bowel segments, and then you give a value. So you can see this is a much harder score to calculate. So if you put it into a picture, actually, this is what it looks like. So this, you see small ulcers, as they get bigger, the score gets better, higher. If you get very bad narrowings or strictures, impassable, that scores points. And you check that in all the 5 segments: rectum, colon, left colon, transverse colon, right colon, ileum, and more than 60 severity. Now, this is a tougher score to do, and during the busyness of your list, I can understand if you can't calculate the score itself. What I would ask you to do, though, is be familiar with the principles. So even if you were in a rush, but you could write to me that the ulcers were small, the extent of the ulceration was 10 to 30%, and there was no strictures, I can always retrospectively calculate the score. But I can't do it if someone just writes active Crohn's disease. So I think for endoscopists, really think about being familiar with the scores of what components they are. So if you're really busy, at least if you describe it clearly to me and to the IBD team, we can work on that. The root gut score is for assessing Crohn's disease after a patient's had an operation like a right hemicolectomy. So essentially it's looking at the anastomosis to see whether there's active disease. And why that's important is because if we know if you have a score of I2, A, or B, the chance of you having clinical relapse of your Crohn's is higher. When you put it into pictures, this is what the endoscopist should be looking at. I1 is little aptus lesions. I2 is where the lesions are just at the anastomosis. I3 is really diffuse aptusitis in the neoterminal ileum. You can see that. And I4 is when you've got large ulcers and strictures. So it's really important for patients who have had operations for their Crohn's that you use the right score, which is the root gut score, when you're assessing the anastomosis. So in a nutshell, those are my take-home messages. Use the right score for IBD, UCIS for ulcerative colitis, SESCD for Crohn's if you can, or describe it for me, and root guts for postoperative Crohn's. When in doubt, describe what you see clearly. Even if you can do that, rather than just using the pro formas, the patient will have a better description. And this is better for the doctors, the IBD nurses, and your patient, because they have a much clearer idea about what's going on. And with that, I'll probably say this is the end of my presentation, but I hope that gives you a better idea about what you should be looking for when you're scoping someone with IBD.
Thank you.
Thank you. Thank you, Dr. Fong.
That's fine.
Also, I think I have, I'm sure our staff has got the same sentiment. Some of these patients, when they're newly diagnosed, they're really, really anxious. So it helps that we can, we can sort of like give them proper advice and give them reassurance. And I know the IBD nurses are getting loads of phone calls from them, especially when after the procedure. So it does help.
Yes, I think providing them the right contact, and I think, like I said, at the moment, most of our referrals will come through our email advice line. The helpline at the moment we are restructuring, so the phone lines really aren't going to be accepting calls at this moment. So that's why if you're going to do any contacts with our BD service, if it's a new patient or a patient that's flaring, let us know through the email is probably the best way, so that we can give you clear advice about it.
Okay, thank you.
So I'll probably give another minute or so for questions, and if there's nothing else, we'll close this session. But I like to hopefully do these sessions every 2 Thursdays or so. And as nurses and doctors, if you have a particular topic you feel that is really good to educate ourselves about, let me know. If I can find appropriate video or we can make a presentation, more than happy. Hopefully this is a good
Thank
way
you
to
for,
develop
yeah,
everyone.
it is,
Steve,
and thank you for supporting us. Yeah.
great,
All
great
right.
presentation. Are there any good information leaflets we can give to the patients after we've diagnosed their colitis?
Yes, I think if you're fairly clear with the diagnosis and your experience with it, there's a lot of information leaflets about Crohn's and colitis in the big cupboard in the the conservatory. But like I said, I think you've got to be very sure what you're doing. If you're not too familiar with IBD or whether it's Crohn's or colitis, the danger is you could give them the wrong leaflet because they're specific for either Crohn's or ulcerative colitis. So when in doubt, let the IBD nurses know, and we can send them the right, information. But if you're fairly clear-cut, it's ulcerative colitis, they will be in there, or you can ask either Sophia, Jane, or Kim where they're kept. But there are leaflets. But when in doubt, the best thing is to refer them to the Crohn's and Colitis UK website.
Cool. Thank you.
All right. Take care, guys, and stay safe.
Thank you.
Cheers,
Bye.
everyone.
Yeah,
Thanks.
thank you. Bye. Bye.
Well done. Thank you.
You know how to know.
Ah, everyone's gone.
I need to have a look at it. Want me to call everyone back?
Are we doing it?
Shall we do a quick 2 minutes just to know what's going on?
Do a quick puzzle.
Quick huddle.